Welcome all to the Global Health Network's 20th Epidemic Ethics COVID-19 seminar, entitled Challenges and Ethical Implications of Distinguishing Between Research and Rollout in Pandemic Responses. My name is Lisa Lee. I'm a US-based infectious disease epidemiologist and public health ethicist. For about half of my 30-year career, I worked at the US CDC, Centers for Disease Control and Prevention, focusing on public health surveillance and the ethics of collection, storage, use, and sharing of public health data. So as a surveillance scientist, I'm just delighted to be here today with our three distinguished panelists to encourage a discussion focusing on the ethical dimensions of public health surveillance, rollout, and research. All right, let's get started. I'm going to briefly introduce our panelists and then define a couple of key terms. Our panelists will then share about 5 minutes of opening comments each, and we'll follow that with a discussion of questions posed by our viewers. Please take a minute to do a quick search of our panelists, where you'll find a long list of their important contributions to this field. I am joined today by Professor Jim Lavery, the Conrad N. Hilton Chair in Global Health Ethics in the Hubert Department of Global Health at the Rollins School of Public Health and Center for Ethics at Emory University in Atlanta here in the USA. I'm also joined today by Professor Jerome Singh. He's an adjunct professor in the Division of Clinical Public Health at the Dalal Lana School of Public Health at the University of Toronto and the Honorary Research Fellow at Howard College School of Law at the University of KwaZulu-Natal in Durban, South Africa. I'm also joined today by Dr. Rika Vandergraaf, Associate Professor in the Department of Medical Humanities of the Julius Center at the University Medical Center, Utrecht, the Netherlands. Now, because there's a great deal of confusion about the difference between these two public health activities, I'd like to offer two orienting definitions so we all are at the same starting line. Public health surveillance is defined as in various ways across the world. Some are very broad, others are quite specific. One way to understand it is to say that public health surveillance is a diagnostic tool that public health professionals use to diagnose their patient, which in this case is the community or population. Data are collected from a community in order to benefit the community. Research, including public health research, is also a systematic investigation, but in this case, it's designed to create generalizable knowledge. In other words, data are collected or interventions are tested on volunteers who risk for someone else's benefit. So with that, let's turn things over to Professor Lavery. He'll take the floor first. Jim?
Thanks for that lovely introduction. So first of all, thank you to Catherine and Dina and the Global Health Network and everyone for the invitation. Very pleased to be here with you this morning. And I'm going to share, I think, 5 to 7 minutes worth of just some high-level thoughts, I think, to get the ball rolling here. And I want to start with the sort of cheeky title of research or implementation, or as you just said so nicely, Lisa, or surveillance. And so the framing statement for today's webinar is, challenges and ethical implications of distinguishing between research and rollout in pandemic responses. And the context, I think, we're all very acutely aware of at the moment is the rollout of COVID-19 vaccine testing and implementation. So I want to start just by giving you a very high-level view of my own kind of view on this issue. The first point from me is that this kind of research or implementation or surveillance problem, I think, is an artifact of policy, guidance, and practice conventions that we have developed over the last 50 years or so. And it's not a real reflection of the nature of implementation programs. Implementation programs, in fact, are hybrids of public health practice and research. So in other words, they are about program delivery by legitimate public health authorities, but they also include deliberate, formalized, and ethically warranted knowledge generation activities. And so the key question is whether our current conventions for applying ethical scrutiny to research projects, in other words, the regulations, the guidelines, the institutional review procedures, and things that we have in place, whether they're fit for purpose to respond to this hybrid nature of implementation programs, the way they really are. And if they're not fit for purpose, then what needs to change? And I think that's really some of the subtext of this webinar. These are complex problems that we still, I don't think, have completely worked out. So why are we experiencing these challenges? So I thought I'd start with just a couple of quick thoughts about context. So one is history. There's a long-standing unresolved debate about whether conventions of ethical scrutiny for research are appropriate for public health surveillance and program implementation. And Lisa has had a long distinguished career at CDC and knows that this has been a long-standing debate even within the Department of Health and Human Services here in the United States, for example, between the CDC and NIH and the Office for Human Research Protection. So there's a very long history about this kind of debate. The second bit of context here is urgency. Our hearts are all going out to our friends and colleagues in India and Brazil and other parts of the world that have been extremely hard hit recently. This COVID pandemic has really created some legitimate urgency to move things forward so that we're not delaying potentially beneficial approaches. The third bit of context is how COVID has revealed the global inequities, both in research and development and also in manufacturing capacities. These things have really come to the surface, and they're relevant, I think, to the way that we're thinking about this problem before us today. The next point is what I call the threshold problem, and that's, what is it that we need to know about key features of the vaccine candidates to justify their implementation in national immunization programs, and I'll say a little bit more about that in a second. The next bit of context that we've been seeing all around the world is what I call regulatory accommodations. So other than potentially Russia and China, there are no other formally approved vaccines in use anywhere. They're all being utilized under some form of emergency use authorization rather than full regulatory approval. And then even with those approvals or authorizations, there are still ethically relevant residual uncertainties that have to be resolved as the vaccines are being rolled out. And there's a moral imperative to resolve these uncertainties. They're not just interesting questions. They really are central questions to our ability to understand the effectiveness of the vaccines and their value as public health interventions. And also their safety and acceptability to populations, as we're seeing with vaccine hesitancy around the world. And one of the things I think that we tend to not think about very much is, what are the core goals of ethical scrutiny in implementation programs? What is it that we're really trying to accomplish ethically, and how best to achieve those goals? These are things I think we often don't think enough about. We kind of take for granted that we know what those things are, and we tend to gloss over them. And then, what are the relevant obligations with all of these contextual factors, and who should hold them? And then what are the appropriate authorities and accountabilities for all of these questions? And so in the last couple of minutes that I have here, I just want to make some very quick high-level comments about three of these. One, the threshold problem, and then some thoughts about the core ethical goals and how best to achieve them. So the threshold problem essentially is a problem of knowing, when an experimental vaccine becomes routine immunization. When does it qualify to be categorized more as routine immunization or public health practice? And so the question is there sufficient clarity and uniformity with respect to the process and evidentiary standards that we employ for regulatory approval, or for even accommodated authorizations, as we've seen with COVID vaccines, of any new vaccine, and for its adoption as routine immunization, for example, inclusion into national immunization programs. So are we really clear enough about the way that we adjudicate evidence to make these decisions. And of course, probably the most important question is how we move from having signals of efficacy that happen in phase 3 trials, where we have a specific endpoint or a couple of endpoints, and we test them in a limited number of people. And then this transition to effectiveness, to how does the vaccine perform when it's out there in the world being given to millions of people? And they're quite distinct, even though they're highly interrelated questions. How much and what kinds of cumulative exposure and safety data are sufficient to deem a vaccine safe? So we have the efficacy and effectiveness set of issues, and then all the safety issues. Are there adequate subgroup analyses, for example? Do we know enough about subgroups? This is a big issue, actually, that we're experiencing here in the United States about vaccine hesitancy within subpopulations. What about groups who haven't been adequately represented in phase 3 vaccine trials? Children, pregnant women, elderly people, people with underlying conditions that have been excluded. What about rare side effects, and what about longer term effects? These are all things I think that are really, really important to our understanding of the performance and the value of vaccines, but we rarely know enough about them when vaccines are authorized. And then what should we do if there isn't sufficient clarity and uniformity in these processes and evidentiary standards? I think we tend to go around assuming that they are clear enough. And what if they actually aren't up to the task? Do we need some kind of regulatory reform, which is always really onerous, some kind of system redesign, some sort of process innovation? I don't know the answers to those, but I think those are some of the things that we need to have our minds open to. And then, does regulatory approval of a vaccine preclude its use in research during the rollout? So does it, for example, does it preclude the ability to use various research methods or designs to resolve ethically warranted residual uncertainties? This is a complex problem. It's received a lot of attention during COVID. But one of the questions is, can we actually clarify the appropriate uses of research methods and designs for implementation programs? So for example, can we clarify when phased introductions might be ethically appropriate, or whether certain types of prioritization of rollouts may be ethically important in both in terms of the ethics, but also in terms of helping us to answer some of these important underlying questions. And similarly with randomization procedures, and there's been a fairly vigorous debate already about whether placebo controls might still be warranted in some circumstances, even with authorized or potentially even with approved vaccines. And then finally, do we have a clear enough understanding of ethical best practices in routine immunization? In, for example, forms of review or scrutiny or oversight that are currently applied. I think we need to kind of understand these best practices that exist already where they do exist, in order to understand the gap between the research and routine practice with respect to ethics. And finally, just a couple of thoughts on the core goals. What is it that we're trying to achieve ethically through our conventions of review and oversight, even just in research? And this is just my thoughts about what some of these ethics goals might be. In terms of substantive goals, we want to ensure that that the host community, the communities that are adopting and implementing these vaccines, has a sufficient understanding or grasp, of the nature of the implementation program, that it inherently includes some of these knowledge generation or research-like activities, and B, what the associated risks and potential benefits might be of participating. The second might be to ensure the voluntariness of individual participants, always a high order question, of course. Then optimize the social value of the implementation program, sort of the achievement of the key public health goals, reducing disease transmission, reducing mortality, reducing hospitalization demand, those kinds of things. And then optimizing transparency and the clarity of the relevant authorities and accountabilities for all of these questions. And then minimize arbitrary, unfair, and discriminatory practices. So they're just an example of some of the substantive goals that we might really care about. And then the procedural goals. have we designed the right procedures and mechanisms to achieve these goals for implementation programs, including the best utilization of existing procedures, guidance, or institutional capacities that we may have developed for research purposes more explicitly. And then very, very last point here, for each of these ethics goals then, what procedures and mechanisms are necessary to achieve these goals for any specific implementation program? This is a really important aspect of it. We can't just sit at the sort of substantive level. We have to think about how to operationalize these ideas. And then our existing procedures and mechanisms and guidance, for example, the ones that we apply day to day in research settings, are they fit for purpose for application for implementation programs? And if they're not, do we need some new procedures or mechanisms to help us over that hurdle? And then what capacities or authorities will be required to put any new or newly configured approaches into effect? So I hope that helps at least get the ball rolling with some initial thoughts about this, and I look forward to the rest of the discussion.
Thank you, Jim, for those comments. Let's turn now to Professor Singh.
Hi, everyone. So Jim has done all the hard work of taking you through all the, I think, the important groundbreaking stuff that needs to set the scene for what we're going to be talking about. And I thought what I would do in my time is very briefly highlight the situation that's emerged in South Africa, but that actually highlights how difficult it is to actually distinguish between research and implementation. And I'm going to just take you through very briefly some of the historical events that happened in the country in just the last few months that I think really speaks to the issue that we are talking to now. So many of you would be aware that the Johnson & Johnson vaccine has been approved by several countries for emergency use authorization. South Africa was one of the trial countries that participated, study participants to the trial. The trial, which was known as the Ensemble trial, aimed to recruit approximately 40,000 study participants. South Africa contributed approximately 7,000 of those study participants. This was a phase 3A trial, randomized placebo-controlled trial. And at the end of January, approximately, the trial results were released. And basically what it showed was that there were varying levels of efficacy in different settings where the trial was conducted. In the context of South Africa, the Johnson & Johnson vaccine showed that it was efficacious in preventing COVID, but in the context of the variant that we have in South Africa, which seems to have immune escape qualities, the vaccine didn't have as high efficacy compared to where trial settings, for example, like the US. So in South Africa, the trial overall showed that it had approximately 57% preventive efficacy, which is, of course, much lower than what it was in the US. But I think it's important just to contextualize it and to say that just before then, the country had actually been engaging with to acquire several million doses of AstraZeneca vaccine. But around about that time, just a few weeks before, the AstraZeneca vaccine trial results were released. And in a complete shocker to the country and to many other people, I suppose, the AstraZeneca vaccine demonstrated even less efficacy. In fact, in the context of the variant that emerged in South Africa, which is known here as the 501 variant, AstraZeneca demonstrated less than 10.5% preventive efficacy for mild and moderate disease. And because there was not too many people who were above the age of 31 was the median age, we couldn't really get any information as to whether this was even going to be effective in preventing disease in older people. So it was a very difficult decision. 1 million doses, or in fact more than 1 million doses, had been delivered to South Africa. Rollout was about to commence, and the government made the decision to pull AstraZeneca's vaccine. So eventually those vaccines were sold to the African Union, but South Africa was now left with a major gap in terms of implementation and programmatic rollout. So the Johnson & Johnson trial had just announced its results. Its results were not good compared to the US results, but of course, this is better than what the AstraZeneca vaccine results were. So the government had decided then that they need to, in fact, try to get access to Johnson & Johnson. It seemed to provide preventive efficacy in the context of South Africa's variant. But of course, the only available drugs that were available were in fact trial drugs. And so the principal investigator of the trial ended up directly liaising with the company, with Johnson & Johnson and Janssen, and tried to get vaccine stock. But this was actually trial vaccine stock. So the short of the long was that the Ensemble phase 3A trial, which was a randomized clinical trial, double-blinded, became a phase 3B single-arm open-label study. And while South Africa's contribution was around about 7,000 participants to the Ensemble phase 3A randomized trial, for the follow-up phase 2B trial, phase 3B trial, the country called its local open implementation trial the Sisonke trial, which means together. And essentially what happened was the fastest way to get healthcare workers onto a vaccine, given that all the setup had already been put in place, was to in fact create an open label implementation trial. And this has caused, as you can imagine, mass confusion because this is being called an open label implementation trial, but essentially it's programmatic rollout. So the principal investigator managed to secure 500,000 doses. And so around about late February, the study participants of the phase 3A trial were unblinded, were offered, of course, the vaccine. And since then, we've now had the Sisonke trial, which is a continuation of the open label. So just not too long ago, literally in the last, I think, 10 days or so, the trial, maybe in the last 10 or 12 days, the trial ended and it achieved its purpose of enrolling approximately 500,000 people. So this was called an implementation trial, but essentially, this is our programmatic rollout that's actually happening. And towards the end, when the study was closing, because there was a specific date that it was due to close, there was mass confusion because, of course, there was rumors that the trial result, the vaccine was going to expire. So many people got enrolled who did not meet study eligibility criteria. So you found people who were actually getting enrolled. So you can imagine there's protocol violations potentially. There's a whole bunch of people who have been enrolled because there was a perception that the study was ending. You're not going to be getting vaccine anytime soon. Get anybody onto this rather than let this expire. And so the principal investigator to come out and say, the stock is not expiring. This is not an expiry issue. This is a study closure issue. But the short of the long was that there's now confusion, and there has been confusion even amongst the 500,000 people who are targeted in phase 1 of our rollout program. We have approximately 1.25 million healthcare workers who are being prioritized for vaccine access. And so 500,000 of those healthcare workers have now been enrolled in the follow-up 3B open label implementation study. And essentially they are theoretically part of a study, but they are, for all intents and purposes, part of an implementation trial. So, this is just a very brief example, a real world example of how you can really speak to the issues that Jim has raised in a really real way, where countries like South Africa, who were a bit behind in terms of securing vaccines, didn't have the financial muscle of course, Europe, US, and other countries in securing vaccine stock quickly, relied perhaps arguably over-reliance on the COVAX facility, but managed to get some stock of vaccines. And the fastest way was through an open label study. But is this a study or is this implementation? And is this in fact programmatic rollout? It's kind of like a hybrid of the two. And so while everybody who's in the trial is supposedly a study participant, in effect, they're actually part of programmatic rollout. So I'll end there. And of course, you can imagine this has raised many, many different issues. Some people are saying, this, even amongst healthcare workers, this caused mass confusion because right at the start, when this was being rolled out, many healthcare workers said, we're not guinea pigs. We don't want this trial to be, we don't want to be participants in the trial. If we want to be participants in the trial, we would have enrolled in the trial. And the government was trying to convince them, no, enroll in this here, you're going to get access to a vaccine that has been given a designation that's similar to emergency use in South Africa. It's called a slightly different mechanism. But as you can imagine, you had this vaccine, you had educated clinicians who were saying, we don't want to actually be guinea pigs, we don't want to be part of this trial. And the government saying it's not really a trial, it's actually a soft roll-in. But again, it speaks to the issues of mass confusion between programmatic rollout and also research. So I'll end there and I'll be happy to take questions a little bit later. Thanks.
Thank you, Jerome. Excellent, vivid example of what we're dealing with here. Appreciate that very much. Really brings Jim's comments to life. All right, let's hear now from Dr. van der Graaf.
Thank you. And thanks, first of all, for inviting me for this important webinar and topic. I think in a pandemic, there's an enormous pressure on researchers and pharma to find, produce, and deliver medications and preventive strategies. We've seen this in earlier pandemics and epidemics like the AIDS and Ebola epidemic, and now also in the COVID-19 pandemic. And I think apart from pressure on researchers and manufacturers, we have witnessed pressure on ethics committees and regulators to relax standards for research. For instance, there have been several requests to use modifications and waivers of informed consent, or to use expedited review. At the same time, I think these activities for testing all these medications in the early phases of the pandemic, they all remain forms of research. And when these requests to accelerate the review process can still be in line with rigorous research, I think there are just few ethical concerns. Now, as regard the rollout of medications in the early phases of the pandemic, then many medications were just used off-label or received approval for emergency use. And time was often too short to conduct proper research. Now, the question is here of this webinar, more or less the challenges of combining research and rollout in a pandemic. And I wonder whether or not it is characteristic of a pandemic to combine the two, and whether it's also difficult to distinguish between the two in a pandemic. And I think that's an empirical question in itself, on which I have no data, and I don't have this very nice, vivid example that Jerome has just presented. But I think it is a question that deserves further study, whether it's something unique to a pandemic. So my claims can only be modest and somewhat from my personal experience as a part of a research ethics committee that evaluated lots of the protocols in the early days. So I think what we've witnessed so far in the COVID-19 pandemic is the frequent rollout of medications, and later on also of preventive measures by means of public health programs without research. And I think in at least two situations. The first situation is that although many research protocols were developed soon after the start of the pandemic, only a few hospitals were able to start testing existing medications immediately in a randomized and rigorous way and in an international setting. So in particular, hospitals that work with so-called master protocols that already were studying patients with similar conditions like pneumonia, they were able to join the WHO Solidarity Trial, which is just now one of the largest international randomized trials to help find an effective treatment for COVID-19. And secondly, now we have proven effective vaccines. They have been administered almost immediately after approval. And in some cases, as Jerome just presented, they may have gone into an open label extension study. But in other countries, at least in the Netherlands, we have only started phase 4 trials now, and the trial and the vaccines have been administered already. So they adverse events are administered by public health surveillance programs. So again, I think there has been a tremendous amount of rollout, both of preventive and treatment strategies, without the classic way of doing research, and that we have to ask ourselves what the ethical implications are of just not combining classic research and rollout. And I think it's important that we conduct as much research as possible in a pandemic, and necessary to prevent patients from receiving from the risk of receiving an ineffective and potentially harmful medication, from the risks of the disease, and obviously as a way to hold a pandemic. But it's extremely important and ethically imperative that knowledge that is gathered is also meaningful, and with just a handful of institutions prepared to act immediately to do research, I think what we could do better for a next pandemic is to arrange for what others have called pandemic preparedness. And so the Coalition for Epidemic Preparedness Innovations, so CEPI, aims to develop vaccines to stop future epidemics. And that's, I think, an important step in this direction, but it's targeted primarily towards vaccines. And another approach, as has been suggested in the literature several times over the past year, is to turn health systems, national health systems, into learning health systems, and that are prepared to systematically learn from routinely collected data when it's not yet possible to do your randomized clinical trial, and to embed them later in your healthcare structure. So the transformation to a learning healthcare system, I think, can also help to gather and register data in a similar way, and so to make the data collected interoperable, so that people in the north of the Netherlands can exchange data with the south of the Netherlands and in other countries in Europe and even globally. And so you can increase the social value of the knowledge gained and transparency of protocols, and at least national coordination and preferably also international collaboration of what is studied by whom may also be essential in such a learning healthcare system. So I think learning activities in a learning healthcare system, such as data collection, might seem to fall within the gray area of research and implementation, but it is primarily the health system that is now rearranged, and not so much, I guess, the principles, the ethics principles that we have available already for learning activities. So I would argue, in line with the CIOMS guidelines, that it's essential that we maintain high ethical standards in a pandemic. And I don't think we need different standards and principles. We just need better arrangements of our health systems to be prepared for the next pandemic. And the most important ethical imperative, I think, is to collect knowledge that is scientifically and socially valuable. That's it.
Terrific. Thank you, Rika, so much for those comments. There's clearly a lot to discuss here, so let's get to it. I want to remind our audience to post questions for our panel using the Q&A function that you'll see on the bottom of your screen. You can look at the questions in there now, and if you see one you'd really like us to prioritize, please go ahead and like that question. Go ahead and like that question, and we will put it to the top of the list. All right, while our listeners are typing in their questions, I'm going to start by asking a question that had come up for me based on all of your comments, and it has to do with whether it makes sense to, as some scholars suggest, to ease ethical requirements during a pandemic when things are, when knowledge is limited and we need information in order to make the right decisions. Or, as other scholars suggest, and perhaps Dr. Van Graaf just did, is it more important than ever during a pandemic, in the midst of that somewhat chaotic experience, to adhere to ethical requirements in the face of a public health emergency? Is there ever an ethical justification to ease those requirements, whether they're requirements for research or for rollout? And why don't we start, Rika, with you, since you brought this topic up. Is there ever an ethical justification for easing requirements around research in the face of a public health emergency?
Thanks. It's an interesting question, and I said a little bit about it in my talk. What I also said in the beginning is that there has been relaxation of guidance and guidelines, for instance, whether you need a wet signature or whether the review process can be accelerated. And those kind of things, I think, are ethically acceptable, because you still can keep high standards in terms of trying to gain socially valuable knowledge. I think it's important to distinguish between just two situations here. So activities that are clearly research, even in a pandemic, should be regarded as research. And keeping high standards here will not only better protect participants from unnecessary risks, but it will also lead to evidence that is gained according to rigorous standards. And I think that's important. And then there are those activities that fall in the gray area. And I think for those activities, there is an opportunity here to mirror those activities to established ethical rules for biomedical research or health systems research where sensible. It's not that there's no ethics guidance out there at all. And I don't think we should regard being in the gray area as an excuse to ignore, intentionally ignore ethical rules, because we have a long history of sensible ethics guidance.
Jim or Jerome, any comments on that?
Yeah, I mean, let me pick up on a couple of things on this. The first point, I think, is just about the way we think about standards in general. And disclaimer, no hostility to standards, but I think it's important to ask hard questions sometimes as well. One of the problems we have in the way that we have constructed the social enterprise of research ethics review, is that we have a very limited empirical basis to determine whether or not all of those extensive activities actually accomplish the ethical goals that we hope that they accomplish. And so to some degree, there's an act of faith that the ways that we have adopted these conventions and designs of the programs are in fact the best ways, that they actually are functioning as effective standards, that they're producing the outcomes that we intend or hope them to produce. I think we need to take that very seriously. I don't think we know the answer to that question. The second part of it for me, Lisa, is that your question presumes that if something has been accepted and adopted as a standard, if it's functioning as a standard and it's been accepted in one context, that failure to apply that in another context, however similar, necessarily involves some kind of relaxation or undermining of the standard. It may very well be true that there are some of those standards that where I 100% agree with Rika that I think it's really important to have some notion of voluntary participation. I don't think anyone disagrees with that. But I think the notion of standards themselves get us into trouble sometimes when we don't have enough basis to know really whether they're the appropriate fit for the kinds of complexity that we're seeing. And I think in some respects, Rika's point about learning health systems is exactly the right direction. And I think one of the implications of that direction for me is that we ought to be stepping back and saying, what are the appropriate ways of thinking, not only about the knowledge generation activities there, but about what it might mean to adopt standards that are appropriate for that type of thinking about knowledge generation and application.
Thank you. Jerome?
I think probably my response would be that just because a guidance document was drafted for research, all research is not necessarily the same. And sometimes we need to be nimble when it's a fast-moving health emergency or pandemic. So for example, there are many, many different norms that were put in place in guidance documents like the Declaration of Helsinki, the CIOMS guidelines, and several others. They were not drafted for rapidly evolving health emergencies like the COVID pandemic. So you'll find that if you just rely on those normative frameworks as the basis for what everything needs to be tested against, you're going to end up with a very inflexible framework to apply to a very nimble context. And you're going to find you're going to probably have unethical outcomes. So I think the challenge for the bioethics community and the research ethics community is to understand that we need nimbleness when there's a rapidly evolving pandemic, and that we need to evolve our research ethics guidance documents. I mean, just as an example, Declaration of Helsinki has not been revised in many, many, many years. It is not suited, it's not fit for purpose. And so we have many guidance documents and many provisions in those guidance documents that are not fit for purpose in the context of a pandemic. And we need to maybe look at some of those issues, and we need to maybe consider what's the best way to move with it. So, my take on this is that just because we have a research ethics framework, nationally there are many, and international there are few, does not mean that they should be robotically applied in every context because they're not fit for purpose in every context. And we need to now respond by developing frameworks. I think the lesson we've learned so far in research is that the implementers of the research, the investigators, have really moved and they've adapted research really rapidly. We don't have 2-year clinical trials before we can actually have emergency use authorization. And similarly, you'll find that that type of context has raised numerous ethics challenges for the research ethics community. We need to now decide now, how does this actually change? Does a vaccine become standard of care? Do you have a placebo-controlled trial in the context of an emergency use authorization vaccine? These are issues that were not thought about many years ago when these documents were first devised. And our challenge now is to decide whether they're fit for purpose, and if not, how do we respond to that? Over.
Great, thank you all. I think that, some overarching themes here are that recognize that there are ethical foundations for the actions, for all public health actions, not just public health research. And I saw that someone, Carla Sands, put in the chat, the ethical guidance for public health surveillance. So recognizing that there is an ethical foundation for the work we do points toward this idea of professional ethics for public health personnel and public health professionals, that we are acting from a place of reflection and an ethical perspective on justice and inclusion and effective and accurate evidence, that just because something is not research doesn't mean it's, do whatever you want to do. There is an ethic, so to speak, behind all of the activities of public health. And of course, the specific concerns about research, that when somebody is putting themselves at risk for the benefit of someone else and potentially not getting the benefits or embracing some harms, there is a different calculus in terms of what we need to do to ensure that those volunteers are cared for. But again, that doesn't mean that the other activities are ethicless, so to speak. So thanks for that. We have a lot of questions from the participants, and I thank you all so much for your insightful comments and questions. And I think one of the things that comes up a lot in the questions, I'm not going to ask a specific one, but just to paraphrase a collection of them, is the issue of how we communicate ethical kinds of concerns and ethical dimensions of what we're doing during a pandemic. And what is the impact of what we tell the public about whether this is a trial, whether this is a rollout, how do we do that effectively in order to live up to our ethical obligation of transparency in public health? And I'm going to just throw that over to you, Jim, as the first commenter.
Okay, well, thank you for that, Lisa. I feel like with a lot of these questions, I'm the old grumpy guy who has, come back to look at these questions again with a slightly more jaded lens. I think transparency is obviously a very ethically important problem, but it's another one of these areas, I think, where the language sometimes, it's very seductive language. We all kind of believe that we understand what transparency means, but when you look at transparency writ large in a complex context like the rollout of COVID vaccines globally, it turns out to be an extremely complex idea. I think we adopt the analogy of transparency, and I think we all think about glass, that we're able to look through and see all the things that we really need to see. But of course, it's never true. We never get to see budgets. We never get to see things like finances. We never get to see a lot of those things that actually really matter ethically. So I think for me, there are two parts. One is that those things that really do matter ethically, we should be pushing as a global community to ensure that we can see through as far as we're able to see. And then for those things where we're not allowed to see, for example, what certain rationales are for prior purchasing agreements with vaccines, upstream things that, what those contractual agreements are for purchases between countries or between individual countries and companies that are absolutely ethically relevant to the kind of situation that Jerome laid out so beautifully in his case study. So I think that there's both, let's make sure that we're doing a good job of seeing the things that people need to see. So for example, in another conversation, Rika and I were discussing the importance of being able to see protocols, being able to sort of have access to study protocols so that people can scrutinize them appropriately and understand what's being proposed. But I think the other dimension, and maybe the more important one in some ways, is to really push for better opportunities to see some of the underlying business and political dealings that really matter. We inherit the deficits and inequity from each of those kinds of decisions. And it would be better if we understood the terms of those agreements. And maybe they're available, but I haven't sorted out how to find them.
Okay, thank you. Jerome, I'd like to toss this one to you. There's a lot of several questions in the Q&A about this idea about justice, and when we talk about the obvious divides and the the continuous divides between high-income countries and low and middle-income countries, there's concerns about the idea that research might be able to help us protect a just distribution of effective vaccines. And what happens, is research and is this knowledge generation a way for us to protect potentially bad actors from duping countries into purchasing vaccines that might not work or that don't have an evidence base behind them? Is knowledge generation really a matter in this case of justice, or in some cases of justice?
It's a complex question, and when you started asking the question, my mind was going to other issues, and towards the issue that you raised at the end, it brought me back to. And as I said, it's a complex issue, and I'll try to give a very quick answer. When you're looking at the notion of justice, you're looking at not leaving people out. Inclusion and exclusion is a justice issue, and I think in the context of just the vaccine trials, we have to look at including countries in vaccine trials. And I think the fact that we now know there are so many different variants and that these variants impact on vaccine efficacy, it highlights for us that you really need to have widespread inclusion of diverse settings in clinical trials. Because had it not been for the inclusion of South Africa in several vaccine trials, we would not have known that the variant that emerged in South Africa seems to be resistant to several vaccines or reduces neutralization activities. So it speaks to the fact that we need to have countries from diverse settings involved in clinical trials, and that we should not presume that, of course, a vaccine that works well in one setting will work equally well in other settings. I think it also speaks to the fact that we also need to ensure that when we're looking at deploying vaccines, now the challenge is that now that we know that variants impact on vaccine efficacy, the big challenge has been, well, which vaccine should go to which setting and how fast and why. And so, for example, I may raise the fact that there's been a lot of controversy in South Africa that we gave away our AstraZeneca vaccines to the African Union. But if the variant that emerged in South Africa is the dominant variant in the region, then surely that vaccine may not work in neighboring countries where they've been donated to. If they're not going to work in South Africa, will they not work in other settings surrounding South Africa when we're the biggest economy in the region and millions of people travel up and down, globally each year? So I think, when you're speaking about justice issues, we're speaking about issues of ensuring that countries are included in vaccine trials, but also that those vaccines that are proven to be efficacious go to those countries where those vaccines are being developed. So if we know, for example, that the Pfizer vaccine or Moderna vaccine works in the context of certain variants that emerge in Latin America, P1, the P2, or the variant from South Africa, the 501, or the new variants that are emerging in India, surely now we should be trying to ensure that those vaccines that are most efficacious and most responsive to those settings actually are prioritized for those settings. For me, one of the big justice issues is that Pfizer and Moderna has said that we're now going to be modifying our vaccines. We're going to make our vaccines so that they are protective against variants like the one from South Africa, and make sure that in fact they are, but the point is that while it's going to be responsive and seemingly protective against the South African variant, it's been prioritized for American populations. surely that should be going to Africa then. So, I think those are the justice issues for me, is that if you're creating a modified vaccine, then the modified vaccine should go to the places where it's needed, not to the places that are worried about getting that strain or that variant. So for me, the justice issues about inclusion in clinical trial activity. It has global benefit, but the issue is also that it should also be going to those countries where it needs to be most responsive. And that for me is a justice issue overall.
Heather, thank you for that. And I agree. It's both about the trials and the rollout. And again, one common kind of ethical dimension of all of this is clearly justice. And we have to consider that in all aspects of our pandemic response, whether it's research or surveillance or rollout. Jim or Rika, any comments about justice before we?
Just a really quick one from me, Lisa. I think another aspect of what Jerome was talking about is, I think about there's a question in the chat as well about how to ensure the social value, and it seems to me that there is an important kind of stewardship role, say, for public health authorities within a country. And I think the justice dimension of it might be something along the lines of a fair equality of opportunity. There are times when, if you look at all those residual uncertainties that I described at the start, where it's pretty reasonable to want to understand, especially with variants, to understand whether or not they are going to perform for your population the way that they've performed in other populations. That can be overdone, obviously, because I think there's some underlying biology that's quite stable. But I think that can be seen as a justice issue as well. It should be reasonable for a public health authority, for a government, to want to ensure that they're really achieving fairness and equality of opportunity. And that requires understanding the social value as determined by the best empirical evidence we can generate.
Any comments on that? Or our last question?
Well, the justice issue is I think at the heart of what is happening now, and I don't have much to add, but I think it's good to be aware that it starts really early in the life cycle already of doing vaccine development and clinical trials. So from whether or not we would be using controlled human infection models and who participate in those sort of studies, to who is included in a clinical trial. So pregnant women were typically excluded. And now vaccines are licensed for them as well. And now justice is moving on in vaccine equity issues, in who gets the vaccine and who doesn't. And I think this is sort of something that we were not prepared of facing, and now we are sort of downstream and we can't go upstream again. So we're just facing with all the ethical dilemmas, and I think they can be avoided, but not at this moment.
Yeah, Lisa, I wonder if I could just say one other thing, just picking up on a point that that Rika just made. We're talking about standards in, say, research ethics and whether they apply the same way in surveillance or implementation. But there are big picture justice issues here that are really, really clear. And one thing that I think has gotten quite a lot of attention, but not enough attention, is whether standards, for example, in trade agreements, are getting the kind of scrutiny that they require, and whether there should be relaxation, various types of accommodation. And we've seen this at the discretion of some companies where they're doing licensing agreements for manufacturing. But there are lots of people still arguing that there is something sacrosanct about the kinds of IP protections that are afforded companies under TRIPS and WTO trade agreements, and that any kind of relaxation, any kind of accommodation would lead to catastrophic downfall of the industry. But we also know that these are some of the most aggressively lobbied industries on earth. And so it seems to me that some of those justice questions have to reach up into those higher order areas like trade, that we tend to not think as much about. They're highly relevant to the problems that we're talking about here because they produce the sort of scarcities that require us to think about these questions that we're thinking about today.
A terrific point, and really consideration we should keep top of mind, but often does not cross the minds of public health professionals as they're facing a pandemic. One last question. I hope we have time for just a quick comment on. It's a complicated topic, but I think it's important to raise this idea that we talk about the ethical standards of and ethical dimensions of the pandemic situation. Do we see a big difference between what we need to be dealing with in an urgent pandemic situation versus kind of regular public health when we're not in a pandemic? Are there ethical dimensions that jump to the fore that we really need to consider differently in a pandemic? And just maybe a quick answer from each of you. I'll start, Rika, with you.
Yeah, thanks, Lisa. I think I repeat myself a little, but still, when it's clear that's research, I think we should just follow ethics guidance that we have for research. And when it's not, when it's more in a gray area and in a pandemic situation, I think we can look at the history of ethics guidance that's out there and be sensible. So try to see what makes sense in a certain context and be transparent about your arguments for not following the Declaration of Helsinki. Give a justification and not just simply ignore what is out there, because obviously we need further interpretation and specification. But when it comes to sort of overarching ethical principles, I doubt whether we come up with something new. Sort of, it's in the specification and the weighing of principles.
Jerome, any thoughts on that? Whether we should be highlighting something different in the pandemic?
Yes, I do think that there are challenging but differences between a regular public health context and an emergency context. I think you have more time to do engagement. Your nature of engagement is different when you've got, like the HIV pandemic is definitely an emergency, but it's more, in my words, a chronic pandemic. It's a chronic emergency that's been going on for decades. We haven't gotten it under control, but it's a different kind of pandemic from a rapidly evolving pandemic like an airborne disease, for example, like COVID. So, you'll find that with a rapidly evolving disease, you may need to have different rules or different ways of engaging or different ways of actually dealing with things. So for me, I'm going back to what I said before. It's not one size fits all. The rules that were formulated for public health and even for other diseases may not necessarily apply in the context of a rapidly evolving pandemic. So we need to actually, have fit for purpose thinking for specific contexts. And I'm saying that we mustn't robotically apply the same frameworks that we've developed 25 years ago when they may not necessarily yield ethical outcomes. Over.
All right, Jim, any quick few seconds left to comment on that?
Just really, really quickly, it seems to me that the answer to your question, Lisa, is looking at what's happening again, like I said, to our friends and colleagues in India. We have 600,000 deaths here in the United States. When you have the kinds of threats of kind of an inability to contain, deadly diseases, I don't think it's about trading off principles. I think it's about looking at whether or not we have figured out how to prioritize these ethical questions and give them the appropriate resourcing and priority. I think we fail on that across the board. And whether or not we can do that in a way that allows us to still achieve those critical public health goals. The public health goals themselves are highly ethical. Reducing disease transmission, all those things are highly ethical. So I think maybe it's about innovation. Maybe we just need to think more innovatively about how to embed the ethics into all these practices.
Well, thank you all so much for what has just been a wonderful discussion. I appreciate very much the viewers' comments and interest in this really challenging topic. I think we've set a couple of sent a couple of nuggets out there for folks to think about, and hope that we'll continue this discussion well past the end of this hour. Thank you all so much for joining us from all over the world. It's great to see colleagues from everywhere and to really engage with you around this topic. Thanks again, and please be on the lookout for this recording to be posted both on Facebook as well as on the Global Health Network's Epidemic Ethics website, and share with your friends. Thank you so much. Have a great day.